College of Health. Sorry about that. We are delighted as the ECSA College of Health Sciences that we have successfully organized the 14th Best Practices Forum. As Senate, our mandate, as outlined in our Constitution, is to facilitate and coordinate our constituent colleges. And I'm happy to report to you that we have continued to increase our coverage in terms of communities of practice. And by the end of this year, we will have 2 more babies born as constituent colleges. We prioritize enhancing the quality of education, research, and publications in the region, while at the same time striving for excellency in professional standards through ongoing development and adherence to ethical principles. As you've seen in our booklet, the quality of presentations that will showcase speaks to what we stand for as Senate. So thank you for the support, and we hope each and everyone will enjoy their participation in this conference. Thank you.
Thank you, Dr. Mwale, for those remarks. I think in many cultures, when a baby or a child is born, what he's also trying to say is, please prepare gifts for these 2 new babies, and that will be soon be born. So that's the normal culture. Let me now invite Dr. Yewande Arimi from the Africa CDC to come forward.
Good morning, distinguished ladies and gentlemen. Standing on existing protocol, I bring you warm greetings from Addis Ababa, Ethiopia, the headquarters of Africa Centers for Disease Control. Your Excellencies, Directors, DG ECSA, it is a pleasure for Africa CDC to be able to support this important initiative to celebrate with you the 50th year of ECSA. We acknowledge the relevant discussions that have gone on ahead of this particular initiative to bring us to the 14th Regional Forum on Best Practices and the 30th Directors Joint Consultative Committee meeting. I think as a start, we must acknowledge the strengths and the value of ECSA that they have provided to the African Union member states, particularly acknowledging the strengthening of the national capacities, be it on laboratory capacity, surveillance, prevention, and awareness of public health threats that ravage our countries, including AMR and tuberculosis, amongst others. We acknowledge and celebrate the regionalism that ECSA has shown, ensuring that no country is left behind when it comes to addressing public health issues. But most importantly, the value of advocacy to ensure that a lot of challenges, gaps, as well as lessons learned from our member states can be elevated to the political level to our ministers of health. Africa CDC acknowledges and reiterates and reaffirms our support to the effort of ECSA as we celebrate with you on this remarkable journey. We will continue to collaborate with you to ensure that we have a safer and prosperous Africa. On this note, I say congratulations once again, DG, and we are honored to continue to collaborate with you. Thank you very much.
Thank you. Thank you, Dr. Arimi. We certainly do appreciate the collaboration we have with Africa CDC. Let me now invite Dr. Emily Pecker from the University Research Council to come forward.
I'd like to first thank ECSA Secretariat, Director General, delegations, and participants for this opportunity and give my huge congratulations on this big milestone celebration. Ongera. My name is Dr. Emily Pekka, and I'm from University Research Company based in the Washington, D.C. area. Through support from the U.S. Agency for International Development, I've had the opportunity to work with ECSA Health Community Secretariat for more than 10 years. I've appreciated working with the Secretariat's colleagues, and in particular would like to appreciate the leadership that Director General Yaswa Dambisia has played in our burgeoning Implementation Science Collaborative, which is a global platform for priority development and research and learning exchange. Our aim is to help improve the use of evidence to improve policy and program implementation. As we reflect today on this important milestone, one striking best practice from our experience is the value of regional cooperation through the ECSA Secretariat and member states. Through support to stakeholder convenings and through the Best Practices Forum and Health Ministers Conferences, this has helped us challenge and shape our activities so that they're more relevant and responsive to the needs of the region. It is such a pleasure to participate in the Best Practice Forum and witness firsthand the power of regional collaboration to move issues together, such as respectful maternity care, urban health and nutrition, mental health and psychosocial support, and preventing and ending violence against children, among others. And I'm happy to say, I think this is my 5th Best Practices Forum, so it's wonderful to be back. It is a great honor to have this opportunity to give these remarks and offer my congratulations. And I wish everyone a wonderful week of celebrations and learning. Thank you.
Right, thank you very much, Emily. We value your support as URC, which you also provide under the Health Evaluation and Applied Research project. Let me now invite Ms. Irene Alenga from AMREF Africa to come forward.
Good morning, ladies and gentlemen, honorable guests, delegates, the ECSA Secretariat. I'm very excited to stand here before you this morning. I'm very proud to represent our organization, AMREF Health Africa. I bring greetings from Nairobi, from our GCEO. And first of all, I'd like to congratulate ECSA-HC for their 50th anniversary. I think during their journey, we've been here together with them. They've been a very good partner to us, and we continue valuing our partnership because we believe in the same thing. And as our motto is, we are trying to create lasting health change in Africa. And ECSA-HC as a secretariat and a regional body has been doing exactly that. And we've been walking along with them throughout their journey. With AMREF Health Africa, we're catalyzing and driving community-led and people-centered health systems while addressing the social determinants of health and having partnerships with organizations like ECSA-HC helps us center and bring all these great innovations and also put our advocacy work in the center and put it in the center of ministerial platforms where change can actually be effected on a policy level. And we really, really appreciate that. So today I would like to congratulate you and offer you our continued partnerships. And I'm sure we will be able to meet in different platforms in this best practices forum, where we're going to discuss very, very pivotal issues that are affecting health in the region and in the rest of Africa, and also have a lot of learning. So I'm wishing you all the best in the rest of the week and hope we have very fruitful deliberations. Congratulations.
Right. Thank you, Irene, for those remarks. We certainly appreciate working with AMREF Africa. There's a lot that we are doing. Now, before we move on to the remarks by the DJCC chairperson, there's a certain friend of ours who wishes to tell us about or raise awareness about the issues of antimicrobial resistance. So I will ask that this friend comes in and speaks to us just in a minute of what we need to know about when it comes to AMR. So I invite the band. Yes, please. Just for 5 minutes or so.
Kutumia dawa bila kumwona daktari, uko ni kufungua ofisi za mikopo mochwaliwe, ugonjwa kukachinja dozi, ni sawa na kuchati na mama mkopu wamekula vyombo we, dalili za homa zinafanana tabia, na sio kiuma kichwa kazani ni malaria, na hiyo lela itakukosi we. Na hiyo lela itakukosi we. Na hiyo lela itakukosi we. Na hiyo lela itakukosi wewe. Sayo moyo me, sayo moyo me, sayo moyo me. Sayo lela itakukotiwe, sayo lela itakukotiwe, sayo lela itakukotiwe, sayo lela itakukotiwe. Ah.
Thank you very much. Thank you very much. I can see people can dance. Honorable guest of honor, high table, and the invited delegates, good morning. I bring to you greetings from the USAID Breakthrough Action Project implemented by John Hopkins Center for Communication Program. My name is Shahada Kinyaga. I am thrilled to be here today and excited to share with you some fascinating insights. Let's dive in. So currently, preparations is currently underway for the high-level meeting on antimicrobial resistance scheduled for September 26, 2024. This meeting convened by United Nations General Assembly aims to secure robust political commitment and accelerate actions across all sectors and levels to address the urgent threat of antimicrobial resistance. This forum will play a crucial role in contributing to the continental position to be presented to the high-level meeting. Tanzania campaign, the band that you've just on antimicrobial resistance stands out as a best practice in addressing this issue. The campaign, known as Holela Holela Itakukost, meaning indiscriminate use of medicine is costly, is a multi-sectoral and multi-stakeholder social and behavior change initiative. It aims to empower public with knowledge, fostering a sense of concern and responsibility by promoting the adoption of appropriate health and safety measures to combat antimicrobial resistance. The character you have just interacted with this morning, the character that was in front of you, is known as Kido, that stands for Kidonge, a tablet in English, serves as the campaign ambassador. Additionally, the band that just played in front of you produced the campaign jingle, which is an essential element in enhancing the memorability of antimicrobial resistant messages for the audience. Thank you very much. You get to interact with the character. Kindly take selfies, take pictures, because this is the Tanzanian ambassador on antimicrobial resistance. Band, over to you. Thank you.
Bila kumwona daktari, upani kukukua ofisi mikopo mochari, hata kukakisha dozi, sasa wanakuziba tumbo la panya kwa mkate wewe, ewe mtoa hukumu zake, ukawa dawa bila kupata mwongozo. Sasa wanakutakia mama mtoto umekula gomba wewe, dalili zaona zinafanya na tabia Así un máquina para tener malaria. Na hiyo leo nenda ikakupotwe. 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 Ufugaji holela, ukiyapata maelekezo ya wataalamu, utaji poteza, upate kubebea kwenye nyaya za umeme, uko tabia za holela,
Ladies and gentlemen, thank you. Thank you very much. Thank you. I think I was it. Thank you. Asante sana. Asante sana. Wait. No, wait. Baadaye. Baadaye. I can see it's getting into, we are going to see lots of things in the gala dinner. It's going to be exciting. So thank you very much to Kido and the band. And thank you so much. I think we are learning a lot. This is already a best practice from Tanzania, actually. So thank you. So let me now invite Professor Osanjo, the chair of the TJCC.
Asante, Dr. Sibusiso, thank you very much. It's inviting me when we were just getting to the groove of it. So permit me to recognize our guest of honor, the regional medical officer representing the permanent secretary, Minister of Health, United Republic of Tanzania, the representative of the regional commissioner, Arusha region, the Director General, ECSA Health Committee, Directors of Health Services here represented, Chair of the Senate of the Colleges of Health Sciences, the Deans of Medical Schools and Colleges of Health Sciences, of research institutions, senior government officials, collaborating partners, members of the media, distinguished guests, ladies and gentlemen, Jambo, good morning. So I'm delighted to welcome you to the 14th Best Practices Forum and the 30th Directors Joint Consultative Meeting held in this beautiful city of Arusha. And the backdrop really is the beautiful and challenging peak of Mount Meru, which I'm sure you've had occasion to see, and also really many nice things, including the beautiful music, which is almost as good as Kenyans music. The musico tamu sana. So, ladies and gentlemen, the theme of the 14th BPF and the 30th DJCC is 50 years of leadership and excellence in regional health collaboration. And the Best Practices Forum is one of the flagship events hosted by the East, Central, and Southern Africa Health Community, that is ECSA-HC, and the forum affords us the opportunity as member states and partners to learn from one another what is working well, what needs to be improved in our settings. Indeed, there is no need to reinvent the wheel when we already have interventions that have been found to be working well and are cost effective. The emergence and reemergence of diseases calls for prudence in how we use the resources at our disposal while ensuring that we implement high impact interventions. I also want to emphasize the use of evidence to inform policy. And it is therefore worth noting that the composition of the Directors Joint Consultative Forum is not by default, but by design. Directors of medical or health services are expected to work with academia and research experts or institutions to ensure that the evidence generated in the region translates into policy and subsequently into action. I can safely say that there is the existence of robust policies at the regional and national level. The question that remains is to what extent these policies have been translated into action. This is a challenge that faces all of us, and it remains an issue that requires our utmost attention. Distinguished ladies and gentlemen, we owe it to the population in the region to ensure that we devise interventions and strategies that are relevant and directed at the root cause of disease burden, and we should reinvigorate our efforts towards reducing the relatively high rates of mortality and morbidity in our region. This may only be possible if we work together and consolidate our efforts and resources at our disposal. COVID-19 posed one of the biggest challenges we ever faced and caused grievous harm to societies and families and weakened health systems. As such, we call upon, and the call to build resilient health system must be adhered to, especially given the fact that we remain vulnerable to such pandemics. It has been shown beyond doubt that regional interventions have the potential to address many of the challenges we face, in particular, controlling the spread of diseases. This being the 14th Best Practice Forum means that a lot of knowledge has been shared amongst us since the first forum was held in 2007. And I'm therefore persuaded that each of us adopted the best practices shared over the years and scaled them up in our respective countries. At the end of the 2.5 days, we need to come up with recommendations that we will be submitting to the health ministers who will meet later this week to make the necessary policy directives and resolutions. Let me therefore ask you to be thorough when discussing the issues under the relevant themes so that we formulate sound, relevant, and practical recommendations. The last 50 years have given us an opportunity to learn and adapt to the ever-changing global landscape as far as the prevention and control of diseases is concerned. And as we discuss the past, let us also look forward to the future so that we position ourselves to respond to any foreseen and unforeseen situations. Let us also keep in mind the main theme, which is 50 years of leadership and excellence in regional health collaborations as we meet and discuss in the different sessions. I wish you fruitful deliberations. Thank you. Asante.
Thank you, Professor Osanjo, for your remarks as the chairperson of the Directors Joint Consultative Committee. Let me now invite Mr. Frank Mbando, who is representing the Regional Commissioner for Arusha Region.
Good morning, everybody. Dr. Omari Chande, Regional Medical Officer representing the Permanent Secretary of the Ministry responsible for Health, Professor Yosua Dambisia, Director General of the East Central and Southern Africa Health Community, representatives of the Intergovernmental Authority on Development, a representative of the African Centers for Disease Control and Prevention, the CDCs, representatives of the University Research Councils, collaborating partners and cooperating partners, senior members of various ministries from the member states, distinguished guests, members of the media fraternity, ladies and gentlemen, good morning once again. My sincere congratulations to the ECSA Health community for attaining 50 years here in Arusha. Congratulations. "50 years is an age of an adult, a matured person. No wonder we have had 2 more kids that are coming aboard. Congratulations. Guest of honor, may I take this opportunity on behalf of the Regional Secretariat and the generous people of Arusha to welcome you all to the United Republic of Tanzania, and in particular, our region, Arusha, we people of Arusha have since been courteous and readily available to host and entertain visitors from around the world. As you have seen, the beautiful dances and all that has been said about Arusha, this is how we are. You're mostly welcome. Karibu sana. And while you are attending your sessions here, rest assured on the maintenance of the peaceful, conducive environment for you to discuss your health issues here in Arusha. The beautiful city, as just the last presenter has said, is second to none. You're most welcome. Dear delegates and guests of honor, as some of you have heard about the beauty of Arusha and the endowment of natural resources, we have numerous natural resources to include the flora and fauna, some of which we have chosen to name them as wildlife and some as domesticated life. I would encourage you all to spare some of your time here in Arusha and visit these mostly attractive nearby sites in Arusha. We have several of them. We have the Arusha National Park, just 30 kilometers from here where we're standing. And it is within the Arusha National Park where the Mount Meru, beautiful mountain, stands. But you can also choose to go a bit further and visit Lake Manyara National Park, which is not very quite far from here, hardly 1 hour drive, and savoir all what Lake Manyara can offer after all that difficult discussions and scientific things. But we have Ngorongoro, the very famous conservation area where to date the wildlife and humans coexist comfortably. You're mostly welcome. Please find time. And the Regional Commissioner's Office is readily available to coordinate your visits to and fro, just to complement your experience at Arusha. Please spare time and visit. Dear guest of honor, I would like also to share my challenge with the scientific community present here today to see how we can, in a more meaningful way, link our research findings and our private sector, especially the manufacturing side, to reduce the over-reliance of our medicines and medical devices being imported from other parts of the world, while we, within the ECSA community, we can have some of them produced here locally. So as we are trying to discuss about the microbial resistance, we are trying to discuss about other medical resistances, we should equally try to figure out how can we increase reliance of the medicines and medical devices from within our community, from within the East Central and Southern African community, and serve our markets in a more meaningful way than relying on imported medicines and medical devices. So, honorable guests of honor, I would like to share that challenge to our land community as they are discussing the researches already conducted. Having said that few, I would like to reassure you, Arusha, and Tanzania at large, we have better and conducive policies already in place to promote industrialization of and production of the medical and medicine, if you so wish, available land, readily available infrastructure, and the entire ecosystem for investors. So should you consider my request, kindly have the Regional Commissioner's Office available as a one-stop center to promote the industrialization, especially in this health sector. With those few remarks, may I once again welcome you all to Arusha. Enjoy your stay. Karibuni sana. Long live ECSA.
Thank you very much, Mr. Mbando, for welcoming us to Arusha. I think I'll just, our job now will be to make sure that no one leaves with even $1. And they spend everything in Arusha. So thank you, sir. At this juncture, it is now my honor to invite our guest of honor, Dr. Omar Chande, to come forward and deliver his address. Sir.
Thank you, Mr. Sibusise. The chairperson of the DGCC, representative of the Regional Commissioners, Arusha Region, Director General, ECSA Health Community, Directors of Health Services, of Medical Schools, Directors of Research Institutions, Senior Government Officials, Collaborating Partners, members of the media, Ngoma Group, distinguished guests, ladies and gentlemen. Habarini za asubuhi. May I use this moment first to welcome you all in Arusha, although my fellow has already welcomed you, but I want to add just more things which has been left on your part. So we have told that we have many areas, interesting areas to visit as our guest, but in the health aspect of you, I'm taking this moment to assure you that Arusha region, as I'm speaking here, has no outbreak which is a threat to you. So use your moment of stay here to the maximum. Enjoy yourself. Karibuni tena. Now let me embark to the remark of the Permanent Secretary that I am presenting here to you. It is my singular honor and pleasure to officiate in this 14th Scientific Forum on Best Practices in Health and the 30th Directors Joint Consultative Committee meeting here in Arusha today. I bring to you all heartily greetings from the government and people of the United Republic of Tanzania. We are very pleased that you are able to find time in your busy schedule to attend this important event. Arusha is a gateway to our treasure national parks, natural resources, and spectacular wildlife. We also have the incredible mankind at Oldubai Gorge in the eastern part of Serengeti Plain, which is also a World Heritage Site. I encourage you to find time and spend a day or two after the meeting to visit these areas. If not, then try at least to get the base of Mount Kilimanjaro. Distinguished ladies and gentlemen, I wish to commend all of you for upholding this important initiative, making sure that we get together on a periodic basis and discuss and learn from each other on the interventions that are making a difference in the lives of our people. And indeed, this is one of the primary reasons for the formation of the ECSA health community. I am pleased to note that this year theme focuses on viewing progress made over the last 50 years. The issues of human resources for health financing, and emerging and re-emerging diseases remain relevant as they were 50 years ago. Notable improvements have been made in several areas, including the training of health workers, allocation of increased funding to health, and reducing the disease burden across the board. However, the challenges remain in as far as achieving universal health coverage is concerned. We need to take responsibility of the important tasks that have been assigned to us, and we need to put the interests of our people first to ensure universal access to health care, and we need to remain professional and important dictates of quality of healthcare provision. Ladies and gentlemen, we now live in the era where we have seen remarkable developments of information technology, including the emergence of artificial intelligence. We must capitalize on these new technologies and consider how best we could adapt it for use in the healthcare services delivery. As such, our discussion should ensure that we appropriately consider these in view of achieving universal health care. Achieving universal coverage in health services delivery remains an important goal that we need to address but need to achieve in this region and beyond. I therefore urge all of you, the government representatives, researchers, and development partners to assist in that regard, and it is crucial that we stay updated on the progress we are making in the region as we move towards the universal health coverage goal. Ladies and gentlemen, the training of health workers with a view to improve skills and numbers should be at the top of the agenda. There is an urgent need for rapidly scale up the number of well-trained health specialists to meet the ever-growing demand for specialists to derive to agenda for universal health coverage. The region still faces critical shortages at health workers, including specialists, and we need to find innovative solutions for fast tracking the production of the deployment of health workers where they are needed. I'm also pleased that ECSA health community is driving to collegiate systems of training, which has the potential of producing the number of health workers to meet the need of our respective countries. I therefore request government representative here to provide the necessary support to ECSA health community and affiliate colleagues to acquire recognition, accreditation, and licensing of the graduates in countries that have not embraced them in fulfillment of the policy solutions in the health ministries. Ladies and gentlemen, as you have noted from the sub-themes of this forum, there will discussions and different sub-themes, including NCDs, human resources for health, mental health and substance abuse, climate change, and health and emerging and re-emerging infectious diseases, amongst others. All these issues require our undivided attention and diligence as we discuss them. We are also looking forward to learn how other countries have devised and implemented interventions to address these issues. Let me extend to call to development partners and researchers, research institutions to provide the necessary support in scaling up some of the best practices that we would be discussed in this forum. And let me also express my appreciation for the support our development partners have afforded to ECSA health community secretariats and the member state. I believe that there is still much more we could achieve working together as partners. I'm very much aware that we face numerous challenges at country level, especially regarding our health systems. And we therefore need to find innovative ways of addressing these common challenges. And and include inadequate financing resources and inadequate geographical access to health interventions. Only a paradigm shift in the way of global, national, and local health and development communities think about and address health systems can result in improved health outcomes and the attainment of the universal health coverage. We should also not underestimate the power of communities. When government partners with communities and gives them opportunities to take charge in their health, we see the rapid and sustainable results that follow. This is the power of partnership. This is the power inherent in ownership. Tanzania is currently embarking on a drive to resuscitate the community health program, and we are ready to share our experience with all of you. Distinguished guests, ladies and gentlemen, to conclude, I would like to remind us of the very important role that this meeting plays in informing policy in our member states, being the highest technical advisory organ of the ECSA health community. And I anticipate that the outcome of the best practices forum of the DJCC will inform the negotiation, the regional agendas for our member states. Tanzania is indeed all other member states have always taken ownership in these outcomes, and they are important in strengthening our health systems. I am sure that the outcome of this gathering will not only sharpen members' state focus on the best way to strengthen health services provision, but also shape the agenda of the next conference of health ministers. With these few remarks, it is my honor and pleasure to declare the 14th Best Practices Forum and the 30th the Directors Joint Consultative Committee meetings officially open. I thank you for your attention. And in this land, we say Ashenale, that is Maasai language to say thank you. Asanteni sana, karibuni sana, na niwatakie conference njema. Asante.
Thank you very much, Mr. Chande. We highly appreciate your remarks. Shall we give the high table another round of applause? Thank you. So we've come to the end of the opening session. We shall now take a break for about 30 minutes, and then we shall reconvene where we'll start with a keynote presentation from the Director General. So I will ask that we go for a photo shoot. I see we are quite a large group. So maybe we'll arrange from outside. Let's see how we arrange outside. So they are going to lead us. It's just, we go outside. It's just in front of those huge banners. So let's do that and then reconvene here in 30 minutes. That should be 11:15. 11:15. So thank you. I see. Ladies and gentlemen, may I have your attention? May I ask those who have gone out to come back? There's a new suggestion which might be more efficient. So let me ask the high table to come sit here. Then I'll ask the DJCC members to come and stand behind. Then we take the photos. Then after them, I'll be calling you to come forward, then partners, so on and so on. So for now, let me ask DJCC members. So that is the representation from the countries, the colleges, and the National Research Institutes. So let's do that. So please come forward. Please come forward. Okay. Yes, I hear. May I ask our collaborating partners to come forward? Yes, please. Please. Africa CDC, URC, University of York, CAMREF, please come forward. That's good. Yes. Let me ask our participants from the Teams project, please. Let's move. Those who have taken the photos can go straight for tea break, yes, so that we save time. Teams. Let me ask our participants from the AMR. The AMR. Those who have taken the photo can go for tea or coffee. Lastly, it's going to be the secretariat. So please don't go out. Secretariat. Next up, secretariat.
Kutumia dawa bila kumwona daktari, uko ni kupungua ofisi za mikopo mochwani, gonjwa kukatisha dozi, ni sawa na kuziba tumbo la panya kwa mkate wewe, ewe mtoa huduma za afya, kugawa dawa bila kupata mwongozo, ni sawa na kuchati na mama mkoki wamekula vyombo we. Dalili za homa zinafanana tabia, na si ukiumwa kichwa kadhani ni malaria, na hiyo lela walisha kukosi we, na hiyo lela walisha kukosi we, na hiyo lela walisha kukosi we. Na hiyo lela walisha kukosi we, na hiyo lela walisha kukosi we, na hiyo lela walisha kukosi we, na hiyo lela walisha kukosi wewe. Hali afya yako na ya mwingine kwa maslahi ya taifa letu wewe, itakukosti nitakuposti, nitakuposti, nitakuposti. Olela yo, olela olela yo, olela olela yo, olela olela yo, olela olela yo. Tukipojali afya zetu, olela olela yo, olela olela yo, olela olela yo, olela olela yo. Wacha kukimbia, imba wewe. Kula waya, kula waya. Aye, olela, olela, itakupoti. Aye, olela, olela, itakupoti. Aye, olela, olela, itakupoti. Aye, olela, olela, itakupoti. Kaki, olela, ukiwa pata maelekezo ya watarabu, tutaki oteka, upati kutembea kwenye nyaya za umeme, kama tabia za olela tutakukosi wewe. Hali afya yako ona ya mwingine kwa maslahi ya taifa letu wewe, itakukosi, 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 olela, olela, itakukosi, 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 itakukosi. One, two, one, two, one, two, one, two, two, two. Yeah. Two. 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 Go. Go.
Yes. May we be coming in, please? So start your second session. May we come back in? So we start our second session. Dear participants, allow me to align with the protocol that has been established earlier. Good morning once again. Good morning. Mambo. Oh yeah, so you got that power. I hope we enjoyed the
Good morning.
from Grand Malaya Hotel. And I take you back to the 14th Best Practices Forum. My name is Ruben Dimbo. I'm a facilitator taking over from Dr. Sibusiso. So I have the pleasure and to pick up the single honor to welcome now you all for this occasion. To begin with, we'll have the keynote speech, and with a single honor, may I call upon the current Director General for ECSA Health Community, provide overarching leadership and guidance to both technical and corporate programs, is driving towards the fulfillment of ECSA-HC's mandate. He also serves in an interim capacity overseeing operations at the ECSA College of Health Sciences, which encompasses all ECSA colleges. Ladies and gentlemen, on the podium, may I call Professor Yosua Mbulalina Dambitsia. A round of applause for him. He'll be taking up the keynote speech on 50 years of leadership and excellence in regional health collaboration. Professor, you're welcome.
Thank you very much, and good morning once again. I was asked by my colleagues to be their mouthpiece this morning to try and distill ECSA Health Community's journey over the last 50 years for the participants. I readily accepted, only to realize that it wasn't very easy to tell the story. But as we were trying to put down a few highlights of the last 50 years journey, one of the colleagues reminded me of this proverb, that as long as the tale of the hunt is told by the hunter, it will always glorify the hunter and not the lion. So it's only when the lion tells his side of the story that a balance will be struck. So ECSA Health Community over 50 years certainly has a story to tell, and we thought we should, as we start the deliberations, reflect upon this. The beginnings of ECSA Health Community were perhaps inevitable. It was an idea whose time had come, and so it had to come into being. And this was in the immediate aftermath of independence in our region. Most of our countries had become independent, and those that were not yet independent were receiving a lot of assistance in the liberation and anti-colonial struggle. The quest for freedom across the whole of Africa and beyond was on. There were lots of pronouncements about African unity, self-reliance, African socialism. One cannot stand in Arusha and forget to mention the ethos behind the Arusha Declaration and the call for African socialism that was the running thread through it. In Zambia, we had humanism in Africa guiding most of the programs and approaches that the government at the time was approaching. Towards the end of the 60s, Uganda had the Common Man's Charter. Across the border in Kenya, the Rambe, which was about collective effort, was on, and one can cite so many other things that other ideas that were driving the processes in these newly independent countries. But what was common in all these countries was the focus on the fight against poverty, ignorance, and disease. With that kind of mindset and grooming, our ministers started meeting informally during the Commonwealth medical conferences, as they were called then. They are now called Commonwealth ministers meetings. But these meetings happened once every 3 years. And the meetings were informal, which didn't seem to serve the intentions of our ministers very well. Consequently, they formalized these meetings into a regional conference of ministers of health in our region, but the same initiative was started in West Africa, though it didn't last. That initiative for West Africa folded after about 3 years. The ones in the Caribbean have also survived, and CARICOM is one of the most vibrant bodies within the Caribbean. Having agreed to meet every year, the ministers realized that they lacked a repository for positions taken, and there was no mechanism for follow-up of any agreed positions. And as I said, so this problem applied to East as it did to West Africa. The early meetings, the annual meetings were to cure the triennial meetings, as I indicated. So the first formal meeting of the ministers of East Central Africa was held in Lusaka in November 1972. That was followed by another meeting a year later in Gaborone, Botswana in 1973. And it was at the meeting in Gaborone that the idea to form and establish a permanent mechanism was agreed to. Immediately that was done, Tanzania offered to host the Secretariat with the guarantee that such a Secretariat would have full diplomatic status. Following on to that, the Secretariat opened an office in Arusha with the first member of staff, who was the Administrative Secretary, reporting on 24th August 1974. He was then followed by the regional secretary, as the chief executive was called then, plus one support staff. So that was the humble beginning of the organization whose 50 years we mark this week. At the third meeting of the conference that was hosted in Nairobi in 1975, the chief guest, who was then Vice President Daniel Arap Moi, among other things, indicated that the establishment of this organization was a desirable development towards coordinating the efforts of the countries. I found a picture of one of the meetings. This was in Maseru in November 1976. That was the fourth conference of health ministers. Apart from a few people that are not included here, it was a fairly small meeting. So when the ministers join us later in the week, you realize how much bigger your organization has become. So to summarize, the evolution of the organization started with meetings of our ministers on the sidelines of the Commonwealth Health Ministers meetings. And then the annual meetings started, hosted by member states. Presently, we have 2 health ministers per year, all things being constant, one of which is on the side or just before the World Health Assembly. The next meeting, which of course starts in a few days' time, will be the 73rd Health Ministers meeting. Over the years, the nature of the meetings has changed from purely policy-level discussions among the ministers to include those of us in this room who are researchers, scientists, civil society, and other stakeholders. And the key decisions of the ministers have over the years been captured and codified as resolutions to guide the kind of follow-on that are required. Among the things that the health ministers have done over the years has been to tweak, adjust, amend, and revise or review the institutional architecture. They have also, over the years, put in place governance structures towards ensuring good corporate governance of the organization. They have, as indicated, recognized and included technical experts within the processes of the organization. And then one of the other things that they have done deliberately is to ensure flexibility in the operations of the organization so that we are not only confined to interactions or cooperation, collaboration among ourselves as member states. The other significant part of the evolution was the change from the Commonwealth Regional Health Secretariat for the East Central Southern Africa to the East Central Southern Africa Health Community. That gave a stamp of ownership of the organization directly to the region and the member states. There has also been, over the years, a significant shift in the approach to how the organization operates. At the beginning, given its small size, the planning was more on an ad hoc basis, based on identified supports and needs. But starting in 1995-96, we went the strategic strategic planning driven way. So with the first plan, 1996, which was for 3 years, 1996-99, that has been followed by 5-year plans. And later this week, we hope the ministers will approve the next plan, which is more forward-looking than the others. It's a 10-year plan. We'll have occasion to unpack it in the course of the week. The other significant shift was the move from purely project-based staffing to establish posts within an organogram and the definition of categories of staff with clear job descriptions. It has already been mentioned that the Directors Joint Consultative Committee was established in 1991 to plug the gap between policy level and the Secretariat staff. So the Directors Joint Consultative Committee was established, and it has provided a lot of guidance to the entire organization in the technical programming. It feeds into, on the lower level, into the Secretariat activities, but also advises the health ministers. And the best practices forum that we are attending this morning was first held in 2007. I was reminded in the lead up to this meeting that I attended the first best practices forum, and apparently I have attended all the best practices forums since that time. So apart from addressing the gap between the evidence which you generate and policy formulation, this is also a forum of shared learning. As indicated, though it was said in jest, we have already learned something from how Tanzania is handling the issue of antimicrobial resistance. That's the spirit in which this forum should be looked at. So presently, with all that has happened over the years, this is how we are governed. The main decision-making body is the Conference of Health Ministers. That is advised or receives inputs from the advisory committee, made up of permanent or principal secretaries, and then the Directors Joint Consultative Committee, to which many of us in the room belong for the technical aspects. I thought I should remind you that the country is in blue and the member states of ECSA Health Community, but over the years, partly because of the flexibility I have mentioned, and partly because of the expanding partnerships that we've forged over the years, we are present in 26 countries as a whole, including one of our sister countries on the West African part of the continent. So the initial program focus had a number of elements, but human resources for health has always been a major issue for our countries, for the region, and for ECSA Health Community. And in the beginning, the organization spent time identifying training opportunities of a short-term nature, but also of a long-term nature, through enabling some students gain admission to universities where that kind of offering or skills didn't exist in the sending country. But as the disc, and then supporting visiting faculty, visiting professors, enabling external examiners to go and attend examinations in different institutions, and also to a limited extent, there was some support to research initiatives, though that tended to be limited by availability of funds. And then with, as the years progressed, the nursing movement evolved into the college, the ECSA College of Nursing, which is now called ECSA College of Nursing, and that was in 1990. The surgeons and others in the room are aware that that was followed by the establishment of the College of Surgeons, COSEXA, and we now have 9 professional colleges. And in 2014, the health ministers made a decision to establish a coordinating body to see areas that lend themselves to harmonization and alignment across the various constituent colleges as they are now. And that was the birth of the ECSA College of Health Sciences. So as we speak now, the results of these colleges are palpable, notwithstanding some of the teething problems that we still encounter in selling the idea and gaining traction in some of the countries. For sure, the college without walls model that our colleagues in the colleges are employing works and is suitable in our conditions. But there is going to be a panel discussion by some of the college leaders. To your left is the logo for the ECSA College of Health Sciences, and to the right are the logos of the colleges that have been established so far. As indicated in one of the earlier speeches here, there are 2 other colleges in formation. They have completed their paperwork, and we shall be for their establishment when the ministers may meet later this week. Hopefully by the close of the meeting, these will be 11. What did I press? I need technical assistance. I think I pressed the wrong. Okay, thank you. There have been other areas beyond human resources for health, and I must apologize that we couldn't put all of them here. So I'll just mention that we've worked to address the poor nutrition status in the region, addressing various, but ultimately all forms of malnutrition, the gross undernutrition, the micronutrient undernutrition, malnutrition, stunting, and so on and so forth. We have, as one of the examples of our involvement in this area, facilitated the development and harmonization of food fortification standards within the East African community in the first instance, and then also in the SADC region. And standards are still in use. This was necessary because part of the sophistication that followed the improvements as we think, it made that more and more of our people are eating processed foods. And as we know, in many of the processes, we lose out on the nutrients in the testers and all that. So we now have to put them back, because you get mealy meal or unga looking very white and nice, but it is devoid of most of the nutrients except the carbohydrates. So the vitamins and some bits of and some of the minerals have to be put back. That's the food fortification. A very important intervention in our view. We've done over the years quite some work on maternal and child health. Where, as an example, once again, we developed guidelines and trained health workers, frontline health workers in the active management of the third stage of labor. And we should like to believe that we contributed to the reduction in postpartum hemorrhage, which is, of course, one of the major killers of our mothers in this region. We have addressed in a multi-sectoral way issues of gender-based violence and child and sexual abuse. And that involvement led to the development of a policy for the management of gender-based violence survivors, or I apologize, I usually don't want to use the victim word. These are survivors. And also developed clinical guidelines for screening and treatment of child survivors of sexual abuse. Regarding health emergencies, and the whole area of emerging and re-emerging conditions that my sister from Africa CDC mentioned, we have been actively involved with partners like themselves in Africa CDC. And we have had a big focus on cross-border interventions in the areas of disease surveillance, outbreak response mechanisms, and ultimately contributing to enhancing the health security in the region. We have, in the process, contributed to beefing up the diagnostic capacity in our public institutions to handle and manage conditions of public health concern. We remain proud of the fact that we have contributed to the expansion of capacities for surveillance and preparedness in many of the conditions that we come across. We are actively involved in aspects of health financing and health economics. To cite some examples, we have previously contributed to the conduct of national health accounts and enabled in a number of the countries for this to be institutionalized. That then has contributed, where these have been used properly, to the design of evidence-informed policies and programs that are guided by rational resource allocation. And we hope that is one contribution to strengthening our health systems. And more recently, we've embarked on programs to strengthen the capacity to generate and utilize health economics research evidence. And I know, looking at my brother Paul from the University of York, I hope there will be some progress report in this regard. We try to address aspects of knowledge management, even though it seems like a fuzzy and ever-evolving field. But this particular forum is one of our contributions at knowledge management, that we provide the platform for you who have the findings to share with the rest, and also take those findings to their logical conclusion by addressing the so what. And then within the Secretariat, we have a knowledge hub, which is a repository for a lot of the research findings. It's a work in progress, but it's your repository. So feel free to share any non-proprietary information so that it can be disseminated partly through our portal. The last the last thing I'm going to talk about with regard to some of the things we've done over the years is our involvement in leadership and management and global health diplomacy. Right from inception, as I will show shortly, the need for skilling up the people that manage our public health sector came up very strongly. But we also realized over the years that particularly at the top, there tends to be very high turnover of the leaderships of our ministries. In a study done in the early 2000s, it was shown that the average lifespan of a health minister on the African continent was 6 to 9 months. So people come, and not everybody who comes into the docket has a health background. So they get in and are grappling in the dark. And this is how the issue of presenting some tips or getting experts to talk to our ministers came up. But after that, then the realization was that if we are engaging only the ministers and the turnover is so high, we will remain with the same vacuum all the time. But then the ministries run on the backs of the senior officials who tend to be more permanent than the political appointees. So we expanded it to involve both ministers and their senior officials. There has been a little lull in delivery of these sessions, but we are going to reactivate it. But another very interesting aspect in the capacity development of the ministries of health has been our engagement in global health diplomacy. As you are familiar with the situation now, there is a lot, everything health is very political. And when we get to some of these meetings without the right skills and right preparation, those of you who have been to fora like the World Health Assembly will realize you can come back home with a resolution which was passed. And when you now start unpacking it, you realize you may have signed off on something you didn't understand. So we in partnership with a number of organizations, including University of Nairobi, Equinet, we even went as far afield as Ministry of Health, Thailand. We set up this global health diplomacy course that tries to equip those of you that represent us in those fora with some of the essential skills. And in addition to that, we have over the years been engaging with our diplomats in Geneva, especially because they are the ones that have a first-hand look at the agenda coming up. So they identify the kind of issues that are so critical to Africa, and we find experts that can help unpack this between the time the executive board meets in January, February, and the World Health Assembly. And this has been one very exciting engagement. As I apologized, it's not possible to speak about everything that we have been involved in. I know some of you, even as you are sitting there, you are saying, what about what you are doing with us? But it's a deliberate omission. Looking through the historical record, one realizes that in the first 3 or so years of the organization, these were the most recurrent issues that our ministers picked up. Shortage of training opportunities, lack of skilled professionals, the high cost of scholastic materials, the communicable disease burden, malaria, TB, trypanosomiasis, schistosomiasis, cholera, typhoid, leprosy. The list is much longer than this. But there was concern about how to handle communicable diseases. Remember, at that time, smallpox was still an issue, though it was on the decline. Then access to health services was a major focus. And this is where some of the decisions and interventions that have helped many of our countries to ensure that most of our populations are within a certain radius from the nearest facility came about. And then you can see there was, at that time, the need was identified for training in management and administration of public health services. And when we are now we are talking about leadership and management, but I'm sure it's the same thing. And then many of you, particularly those involved in areas that utilize lots of equipment, will be familiar with the penultimate bullet, the need for personnel for equipment maintenance. It was an issue then, it is still an issue now. And it is one of the most uncomfortable statements to hear that many of our hospitals have a graveyard for gadgets that have become dysfunctional at the back. When we are in the process of developing the strategic plan I alluded to a short while ago, we asked you in the member states which issues were priorities for you. And you can see once again the health workforce, which came up severally in the early 1970s, late 60s, early 1970s, is still an issue. Health infrastructure came up, especially aspects of ICT, because many of our facilities are of the analog age, and we are being required to do things digitally now. So there is an automatic gap there. And then there is so much volume of health information now. There is a need for robust information systems that when Director Lal is sitting in his office in Kampala, at the touch of a button, he can tell what is happening at a facility in Karamoja in the northeast without having to call or send someone to check them. So the need for that kind of information system that will enable you as decision makers to quickly respond to any developments. The issues of health governance, which not only address the policies and strategies, but also the competences and skills of the people in leadership and management positions came up very strongly. It has been mentioned by the representative from the Regional Commissioner's office, the aspect of health products, the essential medicines, the equipment, and the need for local manufacturing, which is big continental agenda at the moment. Then the service delivery with the emphasis on quality assurance and infection prevention and control, which touches upon, to some extent, the issue that Kido and the team are talking about. And then health financing, including capacity for national health accounts. Why did I juxtapose these two? The priorities then, the priorities now, to show that as much as we have made a lot of progress in our individual countries, we seem to be grappling with more of the same. Whatever we have done over the years has been through very effective strategic partnerships. Of course, our biggest partners over the 50 years have been the member states. I hope it is not something about that. They sorted out the ICT issues we are talking about. Yeah. Yeah, so I was saying the member states, because you have been there for the with and for the organization from inception up to now. You have provided the guidance and you've enabled us to come into your countries even when we are disruptive sometimes. So that has been the biggest partner for ECSA as a organization. And then so many of you have come, have rallied to our call and supported us. I need to mention that at inception in 1974, the organization had only one partner apart from the member states. That was the Commonwealth Fund for Technical Cooperation. Today, I'm sure even the 20 is an underestimate. We have very many partners that we are working with, and some of them have been with us throughout the 50 years, including WHO, both the regional office in Brazzaville, but also the headquarters, the African Union, and then the economic blocs. And perhaps at this point, just to mention something in response to what my sister from Africa CDC mentioned. ECSA Health Community was privileged to be part of the initial discussions towards the establishment of the Africa Centers for Disease Control and Prevention. And we should like to think that we contributed in some meaningful way to the organization taking the shape it has taken, including tasking our heads of states to ensure that this was an African-led and African-owned organization which shouldn't be left to the mercy of our partners and development or otherwise. Because in those initial discussions, there was a very heavy presence from CDC Atlanta, CDC Japan, CDC China, CDC, the European CDC, and it was quite intimidating to bring out some of these things. So for some of the colleagues who are from member states, they couldn't talk as freely as some of us who are for meeting stateless. So we could make the case very effectively, but I digress. Just to indicate that we value the partnerships and we shall continue to engage with you to ensure that we move ahead. So the value proposition we have as we look towards the next 50 years is that we shall build on the successes and at the same time pick lessons from those interventions, initiatives that didn't work out so well. Our record over the past 50 years, and I keep telling my colleagues that you have earned your place in the global community of health actors. So you don't have to apologize for being ECSA health community. The region remains, as we are only too keenly aware, embattled with one of the highest burdens of disease. And we are facing issues of climate change. We are always at the risk, and thank you for the reassurance, Bwana RMO, that there is no outbreak in Arusha at the moment. But we are always at the risk of some outbreak of an emerging or emerging nature. At the same time, we are facing an increasing burden of non-communicable diseases. And of course, we have the unfinished agenda of diseases of poverty and underdevelopment. So the need for regional intervention perhaps couldn't be even more now than it was before. Our health systems require continuous strengthening to ensure that they are resilient, if not robust, to handle the health shocks that they are receiving on an ongoing basis. And as the spectrum of challenges expands, this resilience is going to be called into play much more than before. And so collective action is the way to go. Otherwise, we are going to get overstretched as individual countries. Our dedication then is to continue fostering regional collaboration so that the health outcomes and ultimately the well-being of our peoples in the whole region is improved. Of course, we shall continue relying on you, our governments, on you, our health professionals, on you, our other stakeholders from the non-state actors, on you, our partners from outside Africa, based on common agenda, and of course, on all of us to share what we know works best so that, as one of the speakers already mentioned, we do not reinvent the wheel. In conclusion, then, we are looking at continuing forge unity in whatever we do, and hopefully we will overcome our challenges. I started with a proverb about a lion. Now I will end with a proverb, another proverb about a lion. I don't know if I've captured this properly, Prof. Bekele, that when spiders unite, they can tie down a lion. So if our problems are roaring at us like lions and we are weak spiders, let's unite and tie these problems down. Asanteni sana. And once again, welcome to the Golden Jubilee celebrations. Thank you so much.
We are the spiders, and we unite to take down the lions. A round of applause for the professor again. Thank you, Professor, for your very in-depth presentation that I believe we have had. For those with my history who have never been at the beginning of when the ECSA was starting the journey, at least we have been driven together, and at least now we have the bigger picture on how best this is helpful to the communities. Another round of applause for everyone who have contributed to the better of the Excel. Professor, I hope we won't mind it to take at least 2 questions in response to the marks for now. So may I? Okay. Professor says he has the bigger team and they will help to do that. So may I allow at least we have 2 questions to take over a contribution or something. We have one from the representative from Mauritius. Can I have another hand? Here.
Thank you, Professor, for such an in-depth presentation of this subject. It's an eye-opener for all of us who are new to this forum. Two things which draw my attention was, one is the capacity building of the human resource for Africa, and the second one was the management and leadership skill that our ministers need to engage with. I would extend, it's more of a suggestion than a question, and it's about the leadership and management skill need to be really ingrained in our system, because most of our, next to the minister, are also many doctors who advisors of ministers, and many of them are just clinicians, and they don't really have the management skill and leadership around the process. So I would suggest that this training course, which is extended to the ministers, need to be also ingrained in the system so that it more or less becomes compulsory for these people who want to achieve that level of function, need to have this type of skill. So thank you.
Thank you very much. Can you have the second hand? Likely it comes from the representative of a different, the female representative. Yes.
Yeah, thanks a lot for the great talk and the great work being done. I note the various priorities that are being suggested, but I want us to note that even when we tackle issues around healthcare, strengthening health systems, it's important that we bring on board issues related to gender. I didn't see that in, and I'd like to ask or understand whether gender strengthening, because we know the healthcare force, gender is there, the community issues of gender need to be considered. And here I want to bring on board the part of increasing women in the decision-making process, not even just executing, but decision-making process, meaning from leadership to the point of creating a work environment that encourages women's participation. Thank you.
Thank you. Thank you very much. Just a quick response, Professor.
Thank you very much. From Mauritius, as I hinted upon in my presentation, initially we were targeting the seminars for ministers only, but we realized that we need to bring this to the next level where the senior officials are involved. But beyond what is what happens on the sidelines of the ministers' meetings, we actually have a course developed. We were about to roll it out when COVIDed and put everything on hold. So we have opportunities for senior officials that accompany the ministers to be part of that training, but we also have and are in the process of rolling out standalone courses in leadership and management for other health leaders in our countries. But thanks for the comment. We have taken note. And I think the message for my colleagues from the Secretariat is for us to fast track the process of reviving these courses for the rest of the health leaders. I did not include gender, and I did not mention it because it is in our thinking one of those cross-cutting issues. So for every priority area, we are going to factor in the gender, and I think our gender specialist is satisfied that throughout all what we plan to do, that will be reflected. But even if there is an omission, because the implementation arrangement for the 10-year strategic plan includes operational plans that are 3-yearly or so. So we have an opportunity during the development of the operational plan to ensure that whatever was missed out in the broader intentions is captured there. Once again, we have taken note of that. Let's ensure that gender doesn't fall through the cracks. Thank you very much.
Another.
My colleagues itching to say something? No, okay.
Thank you. Another round of applause for the professor, please. Thank you so much, Prof. For now, we will be, I'll be taking you now to the sub-theme 1 for the human resources for health, which will now be chaired by Eswatini. And I have the honor to welcome here Dr. Sipiwe. She told me she's Sipiwe Twala, if I have correctly pronounced that. She's from the Faculty of Health Sciences, University of Eswatini, formerly Swaziland, PhD in Public Health, Health System and Policy, Research in the Health System, avoiding HRM, including HRM, training nurses and the midwives, pre-service and in-service. She's an administrator at the university engaged in remitting, developing, and coordinating HRM. Ladies and gentlemen, on the stage, the chairperson from Eswatini, Dr. Sipiwe Twala. You're welcome.
I don't know if I'm visible. I'm usually very short. The Director General for ECSA, the Secretariat, the Chair of the DJCC, guests of honor, and distinguished guests, good morning. I think it's Habaru in Habari. Swahili is a little rusty. I will polish it over the next few days. So in this session, we shall be looking at human resources for health. I think our Director General has already put down the background very well. We have lots of challenges, and human resources seem to be a problem globally, actually, even in the high-income countries, but more so in our setting. And we do have paradoxes in the sense that we are short of capacity, we are behind in our training, but even after we have trained, we struggle to retain our health professionals. And when we do try to retain them, we don't have posts, our governments don't have posts to absorb. So it's really a paradox. And also we struggle with trying to maintain a health workforce that is efficient for the health system. Affordability is a problem. So we often have to grapple with finding the right kind of mix for human resources. We need specialists, but if everybody is a specialist, then we have other problems. But if we have no specialists, we have other problems. So let us have this time to learn from others what they have done. So in that light, I would like to call our first presenter forward, who is the Director of Human Resources in Zimbabwe, Ms. Jane Mudaria, to come and tell us, show us a few things of what they have done in Zim to deal with this problem. Please come forward, ma'am. I'm sorry if I have murdered your name. Thank you. A round of applause. Please.
Thank you. Thank you very much, Madam Chair, Dr. Twala, the Director General, ECSA, the Chairperson of DJCC, all delegates and all protocols observed. We thank you for the honor of allowing Zimbabwe to share its journey when it comes to health workforce issues as we move from evidence to policy and then also to action. I'm attending this meeting with my colleague, Dr. Jainesh Mutede. Dr. Nyamayaro, who was supposed to be with you, could not travel. We hope to see you on Wednesday so that we can then continue to learn from you colleagues. In sharing our story, I'll look at the summary of the evidence that informed the health workforce strategy and also development of the compact. The situation analysis when it comes to health workforce matters, how we used the evidence that we gathered, including the multi-sectoral approach in tackling the health workforce challenges that have been alluded to by the DG and the chairperson of the session. We will just flag four most important findings for us, and then the implications and opportunities guided by the health labor market analysis findings, which the DG also alluded to. We'll talk to what we are proposing to do through the Health Workforce Investment Compact to drive action towards addressing some of the challenges that have been flagged. Lastly, we'll share the lessons that we believe other countries can benefit from the processes that we went through. Our health workforce analysis, we're happy that through the National Development Strategy, the government is committed to attaining upper middle income society by 2030. In order to do that, the government finances the greater share of the public health workforce complemented by development partners. We've got a total of 52,000 established posts, of which 5,000 are vacant, but you find that is indicated some of the posts are vacant because we don't have takers for those posts, or our production is not up to what we're supposed to have, as you also note as I present. We are happy that the Health Service Commission was introduced through the amendment of the Health Service Act in 2022. The Health Service Commission, for us, will help scale up and flag, as well as give prominence to health workforce matters in this particular area where we're trying to complement the implementation or attainment of the upper middle income society through health service provision. The health labor market analysis was conducted in 2022 by the Health Service Commission and the Ministry of Child Care, with technical support from WHO and financial support from the Global Fund. This enabled us to have facts that relate to how the health labor market is structured, and also flagged what issues we would want to address in terms of the imbalances, the skills mix, any surpluses, any shortages, and also be able to track performance and productivity of the health workers. Guided by the findings of the health labor market analysis, which was shared with the relevant stakeholders, we then went on to develop a health workforce strategy. This is simply summarizing for the benefit of colleagues the journey that we traveled since August 2022, when the Health Service Board then, which is now the Health Service Commission, undertook a partial analysis of the health labor market of specialists workforce. Then in 2022 August, the Health Service Commission also developed a human resource for health policy. Then August to December 2022, a health labor market analysis was conducted. This was followed by a health high-level policy dialogue on the health workforce in February 2023. And we have a health workforce strategy for 2023 to 2030, aligning with the vision of the country. And then we now have an investment compact, which we hope will be signed by end of June. What reasons do we have for conducting the health labor market analysis? This was really to look at the continuous systemic challenges that have been alluded to by the various speakers, the shortages of the health workforce, their migration, the unstable currents for us, and other macroeconomic challenges that present challenges in terms of training, retention, and management of the health workforce. This and all other issues will require multi-sectoral consensus as well as action. COVID, I think we all are aware, worsened the out-migration and shortage of the health workforce that is required for service provision. We are grateful for donor funding, which supplements government efforts towards sustainability and transition when it comes to health workforce matters. For Zimbabwe, the training and education capacity, unfortunately, we're functioning at 75% of our capacity as a ministry. We do have courses that we run for diploma courses as well as post-basic courses for nurses and environmental health technicians, as well as other professional categories like pharmacists, hospital, food service supervisors. The inefficiencies when it comes to production are due to shortage of teaching staff. The majority have migrated, and we also would need to scale up following COVID in terms of digital learning platforms. There's also the failure to attract applicants in most of the postgraduate courses is the incumbents either seek to migrate or move to other areas. Then there's also the inadequate infrastructure that the DG alluded to and tools of trade for the members to be able to function well. The in-service training as well is not being done comprehensively and consistently to be able to build the relevant capacities for members to perform well in their respective portfolios. The migration of health workers, which I alluded to, focuses mostly on the out-migration of health workers, and it continues to affect both the public and private health sectors. For now, it has kind of stabilized, but it reached its peak in 2021 when the majority of the health workers were moving to the United Kingdom, Ireland, North America, as well as Australia, in addition to other regional countries. Like I said earlier on, the four most important findings which guided the policy reforms and the investments that the country seeks to make was that we continue to experience a supply-side failure, which is characterized by a deficit between the demand and supply of health workers, as indicated in my initial slide. We've got about 5,000 vacancies, which include also training posts. Then the huge deficit between the need and supply, where we are only meeting 47.5% of the need from the production side. The inefficiencies in production, training, and development of health workers, like I said earlier on, we're only utilizing for now 75% of our training capacity, but we're hoping to increase this to 100% by the end of 2025. Then also the average transfer earnings for the health workers was US 895, leaving a gap of 463, which is average. It varies by category or professional category of the health workers. Like I said, we needed stakeholders to come on board for a multi-stakeholder approach. And how we mobilized was that in August 2022, there was a stakeholder mapping of those in the health workforce as part of the political economic analysis. Based on the findings of that stakeholder mapping, a multi-sectorial technical task team which included key government ministries, development partners, and donors and regulatory bodies, who are the key players when it comes to health workforce matters, was formed to drive the process of the HLMA, the development of the health workforce strategy, as well as engagements when it comes to health workforce matters. We reviewed the strategy, the previous strategy, which ran from 2017 to 2021. We are fortunate that in Zimbabwe, we have got a commitment or buy-in at the highest levels. The Health Service Commission is really key, as well as the Honorable Minister, whom you met on Thursday and Wednesday, as well as the top management team, and also the key stakeholder ministries in government have also been on board, including parastatals and regulatory bodies, as we journeyed in this process. As a country, we require at least 40,000 community health workers who are really critical when it comes to service provision at community level. We are hoping that we'll progressively integrate community health workers and boost their numbers, and this includes primary counselors, so that by the end of the compact period, which is a 3-year program, we'll improve the density to 18.5 per 10,000 people in the community. We're hoping that every community or village health worker will cover at least one ward. Currently, some are covering 2 wards, which becomes a challenge when it comes to the workload. Based on the evidence, we would want to improve their allowances. Currently, they receive $14 per month, which is paid quarterly. It is hoped that by the end of the 3 years, we will have significantly improved the allowances with support from the Ministry of Finance, complemented currently by donors, mostly the Global Fund. As we focus on the 3 years of implementing our 7-year strategy, we have picked priority areas which are around planning and finance, where we seek to increase the investment in the health workforce from the current $9 to at least $32 per capita, which for us will be slightly higher than the regional average of $24 per capita. The intention, though, is in the long term to be able to migrate to $55 per capita. On production, training, and development, we seek to increase intakes so that we produce the health workforce that is required and even have extra to share with other countries. This would also involve refurbishment of the training schools and establishment of multidisciplinary training schools, so that we invest well and utilize the digital technology that we have. It will be important for us to manage retention as well as migration. You'll find that if we produce and we don't retain, we'll only be doing ourselves down, and we would want to learn from colleagues as we interact during the ministers' meeting in terms of how we can improve retention. For us, this includes provision of tools of the trade, how we are managing the health workers themselves. And I'm happy that ECSA is investing in training of leadership and management, because that is crucial to how we are able to retain the health workers at various levels. And I'm also happy, maybe just to go back to training, on the existence of the various colleges of ECSA, which provide colleges without walls, which enable health workers to be able to be trained on site as they provide services. We also need to invest in ICT, research, health information systems, and digital learning platforms to cover the gap of shortage of tutors in the various disciplines. So for us, the policy implications with the adoption of the 80 Service Coverage Index for universal health coverage is a strategic direction for the country, as well as utilization of the evidence on wage expectations that was gathered from the members that were interviewed, and then progressively review the Ministry of Health establishment to be able to provide the numbers of health workers that are required for us to be able to attain the service coverage that we're talking to. This summarizes the tenets of our investment compact, where we are seeking to attain the universal coverage index of 80. We intend to do that by doubling the health workforce. And how do we double the health workforce over the next 3 years? We'll progressively increase training and education to at least 7,000 per year. We'll expand absorption capacity with support from Ministry of Finance, Economic Development, Investment Proportion, by creating an additional 32,000 posts over the period of the strategy, as well as ensure their equitable deployment in the various service provision areas. We would seek to reduce attrition by 50% through appropriate retention schemes. And this is supported by strengthening leadership and governance, as I said earlier on, as well as with support from finance, increasing workforce financing investment to at least $32 per capita. Cross-cutting in all this is for us to continuously monitor and evaluate ourselves towards achievement of the goals that we have set for ourselves. So for the investment compact, which is a 3-year strategy, we are saying this compact, health workforce investment compact, is voluntary, it's open, and it's concrete and flexible. It's voluntary in that it's not enforceable through a court of law. The key stakeholders are free to come on board, where there's promotion of peer-to-peer accountability, so that we can ask ourselves or each other whether we are honoring the commitments that we saw made to address challenges in the health workforce. And it's an open compact in that those partners that might not be able to sign by the end of June, when we do sign, will be able to come on board guided by their respective portfolios in terms of the areas that they would want to support, guided by their own portfolios as partners. But they have to align with priorities that have been agreed to in the compact. And it's flexible in that the priorities are concretely defined and agreed, and compact partners are then free to align with any specifics that talk to their own mandates. It recognizes the existing commitments and does not replace any agreements that the government might have with the respective partners. The compact areas summary is: 1, aligning and synergizing our efforts to increase health workforce investments from the $9 to $32 per capita per annum. We would want to double the health workforce by 2030 through expanding training and education output. We also would seek to expand our staff establishment to create at least 32,000 jobs by 2030, and this translates to about 14,000 in the period of the compact, which is 2024 to 2026. We seek to progressively integrate village health workers, including primary counselors, to boost their numbers to at least 23,000 by the end of 2026. We would also need to invest in the health workforce retention and sustainable migration, so management of migration, because whether we like it or not, migration will happen, but we need to be able to manage it in a sustainable manner. And then lastly, we intend to invest in strengthening the health workforce monitoring and accountability, and this includes investments in digitalization of the various systems and platforms. What lessons can colleagues take from this process for us? The success factors is really critical for buy-in from not only top management in the Health Service Commission and the ministry, but also government-wide. This will then cover the multi-stakeholder approach, where we need to make sure that the key government ministries, in our case, will be Ministry of Finance and Economic Development, Ministry of Foreign Affairs, Ministry of Labor and Ministry of Higher and Tertiary Education for the production of the graduates that we recruit in the health sector. It's also important to keep development partners, be they local, regional, and international, informed and also get their buy-in when it comes to health workforce matters, as well as engaging and involving. For us, we call it a health workforce technical working group through regular meetings and consultations. As a country, we benefited from technical support from WHO, AFRO, and our country office, as well as the Global Fund's financial assistance in this process. It's also important to have one-on-one engagements before undertaking roundtable negotiations, be it with the key government ministries, be it with the development partners. What we recommend that other countries who might want to go through the process should avoid is letting your eyes off the ball, because you set a roadmap, and if you're not careful, before you know it, you probably would have overrun your timeline. So you need to make sure that you've got a team that is committed to making sure that the timelines are maintained as much as possible. It's also recommend that you engage your key government ministries first, so that you've got a common government position before you go out to engage the other partners. And key to this will be the Ministry of Finance, because they provide the government resources. The health labor market process is really intense and requires the countries that seek to undertake HLMA to have a dedicated team that is fully supported by top management and is supported fully in sticking to the roadmap that will have been agreed on. And we recommend that countries avoid engaging development partners. We have got heterogeneous interests in open meetings, because that might derail your discussions, but you can engage them on a one-to-one. Chair, I do submit our presentation as Zimbabwe. We look forward to meeting you all on the 19th, conversing and learning from you. I submit. Thank you.
Thank you, Mayor Jane, for the presentation. I hope you remain online a little bit. Seeing that you are virtual, they might not be able to stay for the duration of this session. So perhaps you could take one or two burning questions for the presenter online. Do we have?
It's okay, Chair.
Thank you. Any quick question or? Yes, sir. We have a couple this side.
Okay, thank you for the presentation. The question not specifically for Zimbabwe, but I also wanted to ask the DG, because we are constrained, the population will continue to grow. There are workforce challenges, the numbers, and even health financing and infrastructure. But I'm trying to think that one of the key innovative approaches, which probably could be able to help us for people to access care, just like it happened during COVID, is the aspect of self-care. So probably how can we be able to promote the agenda of self-care so that people take care of the individuals? When we are thinking of aspect of mental health, aspect of NCDs, aspect of sexual and reproductive health, like already we have self-injection, we have people injecting themselves for diabetes. I think it's be able to, the dividends will be far much more. We reduce the number of people queuing in our facilities and also reduce the number of the health workers which we need. So it's actually one of the things which is, I'm proposing that probably we need to be able, the ECSA should look at and see how countries can be able to promote self-care.
Okay, thank you, Mauritius. Thank you, Uganda. Mauritius has a quick question. We will have a discussion session, ladies and gentlemen, so.
Yeah, my question to Mrs. Jane was, in Mauritius, most of our workforce is bundled under the civil service system. And she mentioned about the Health Workforce Commission. So I would like to hear from her, how did she go to that shift? I don't know whether in Zimbabwe it was always a Health Workforce Commission, or it was part of a civil service infrastructure. That's one. And second thing is, how did she manage, or she's managing the migration element, which is so rampant across Africa at least? Thank you.
Thank you, Mauritius. I don't know if you got that, Jane. One was a
I
comment.
did.
Yes, please respond.
Thank you very much, colleagues, for the feedback and the questions. I don't know whether Dr. Mtede will be able to talk to the suggestion on self-care from a Zimbabwean perspective. But for us, the Health Service Commission we started off as part of the Public Service Commission. Then we migrated to being managed by the Health Service Board, which reported to the Honorable Minister. But through engagements and conversations, it was seen that it was really important for the health sector to have its own commission. There were protracted struggles because there was a commission that had made this recommendation in the 1990s, but it was only implemented in 2022 when the Health Service Commission was then established, and they are still in their initial stages, but we hope that going forward, they will improve on the management and oversight on health workforce matters as they relate to those who are employed in the public sector. And then when it comes to migration, yes, it remains a challenge. The ministry has been engaging and continues through the Health Service Commission, or led by the Health Service Commission, seeks to have stakeholder consultations in terms of how we can benefit from the out-migration of health workers and also manage migration internally. Thank you very much.
Thank you.
I don't know whether Dr. Mtede would want to comment, Chair, my colleague who is also online.
Okay. Your colleague can just speak if ready.
She is muted. I think you can proceed for now.
Okay, thank you very much, Madam Jane. Can we give her a round of applause? Thank you very much. So I'm sure there are
hello?
points or points of discussion
Hello?
and
Sorry, Chair, Dr. Mtede is now ready to comment, if you'd
right.
allow him.
Yes. So good morning, Chair. Sorry for that. Just a comment on the self-care. It's something which the country is also looking with, and we are working together with our partners. We have various programs which are already looking into that, especially with the adolescent health. We know that our young people are active, they are healthy, and usually they do not want to come to healthcare facilities. So self-care is something which we are really pursuing. As well as for family planning, we've got self-injections which the population can actually do, and this is an avenue which we are looking at, as well as even in our cervical cancer screening, collection of HPV DNA tests. The population actually collects on their own, and then they are submitted on their behalf to health institutions. So definitely self-care is a model that the country is also looking at. Thank you.
Thank you very much, Doctor. Can we give them a round of applause again? Hoping that we don't lose you so that you can hear the rest of the presentation and perhaps be part of the discussion. I do note that the self-care element leans more towards primary health care again. leads us back to that old Alma Ata declaration once upon a time. So at this point in time, I would like to invite the CEO of COSEXA, Ms. Stella Itungu, who will tell us about the collegiate model in developing human resources for health at the ECSA-HC. Can we give a round of applause, please, as she comes forward? Please.
Thank you, Chair. I will ride on the protocol already observed by the previous speakers, distinguished delegates, ladies and gentlemen, good afternoon. Stella Itungu has already introduced the CEO of COSEXA, the College of Surgeons of East Central and Southern Africa, headquartered at the ECSA-HC Secretariat here in Arusha. I compiled a presentation with my colleagues, and at this point I would like to recognize them from different colleges. Our presentation takes into account all the ECSA colleges, but examples are from a few colleges, especially on the activities done in the region. At this point, I would like to recognize Lemi Mabuga from the College of Nursing and Midwifery, Judith Andrew from the College of Obstetrics and Gynecology, Sophia Masuka from the College of Anesthesiologists, and Godfrey Sama that put their efforts in this presentation. I'm sure we all relate to what we are seeing here. This is someone who has got quality care, and you can tell by the smile. By looking at him, I'm looking at my father in the hospital. I'm looking at my uncle right now in Mulago Hospital. I'm looking at my niece. And we all deserve quality health care. But how do we get to quality health care? It comes out through training, quality training, and all other aspects related to health systems in the region. Without risking preaching to the converted, I know the DG has already given us an introduction of ECSA-HC way back 50 years, and it incorporated also the establishment of colleges. We had several calls, and we are still having calls, and these calls come from international organizations. They come from us ourselves in different meetings on how to approach the health sector and its related challenges. There were calls in the region by the health ministers. 3 to 4% of the health workforce only forms the global health workforce, and that's from Africa. But Africa suffers 24% of the global disease burden. Yet there's a shortage of 7.2 million. In 2015, the shortage was standing at 4.3. By 2020, the shortage was at 7.2. And according to World Health Organization, these shortages will rise to 12.9 by 2035. The health ministers, in their wisdom, they mooted the idea of having colleges within the region. And what was the main intention? They saw the gaps and noted the gaps in the health workforce in the region. The gaps were ranging from costs of training, the limited specialists in the region, and brain drain, hence the establishment of the colleges. This was also in the DG's presentation. I'll give it a different approach. Yes, we have 9 colleges, but the ECSA health community has really achieved a lot. 1990, there was 1 college, College of Nursing. 1999, the 2nd college. 2014, the 3rd college and the umbrella college. Between 2014 and now, there are more colleges, but in total 9 colleges. The DG has already informed us that by the end of this week, we'll have 2 more colleges. What does it tell us? ECSA, as we celebrate the 50 years, has achieved a lot in terms of developing the capacity of the health workforce. We have 9 colleges: ECSA-CON, College of Nursing and Midwifery, ECSA-COG, College of Obstetrics and Gynecology, COSEXA, College of Surgeons, College of Ophthalmology, College of Physicians, College of Pediatrics and Child Care, College of Oncology, and I would like to recognize the presence of the leaders of these colleges, Professor Abebe Bekele, the SG of COSEXA, Professor Annette Nachmuli, the president of ECSA-COG, Dr. Chalwe, the president of ophthalmology, Dr. Mpoki Ulisuvisia, I hope I mentioned it right, the president of CANEXA, and Dr. Glory Musibi, the president of ECSA-CON. These are distinguished leaders who manage and run the operations of the colleges on pro bono basis. They are not paid at all. They have their other work, but they committed and volunteered to delivering the health workforce development in the region. We appreciate them. In trying to develop the capacity of the health workforce, all colleges have different programs, different specialties and areas of enhancing the skills of the health workforce in the region. COSEXA, you will see, I'll not mention all of them, but they range from general surgery, cardiothoracic, breast surgery, orthopedics, otorhinolaryngology. We have ECSA-COG, which has also 5 programs. We have ECSA-CON, has 6 programs. CANEXA has 2 programs. These are the programs that are undertaken by colleges, and these are only 4 colleges, but there are other colleges we've not mentioned. What does it tell us? We have a very broad scope of enhancing the skills by touching every aspect of quality care, training, research, and education. My aim of talking about all this is to bring us to where we've come from and where we are now in terms of the achievements ECSA has made through the colleges as we celebrate our 50 years today. The colleges have different approaches in terms of its training. We don't just wake up and start. We have to have the goodwill of the governments, of the ministers, much as they are the ones that established the colleges, but they must approve what we do within the region. We also have a group of leaders, I've already mentioned them, the governance structure, which has the council, the executive committee. We also have the secretariat, the country coordination teams. We have the country representatives, but also the umbrella body, which is the CHS, that has affiliate colleges for 2. In terms of training, our training is on the job. It's practical in those accredited sites, in the hospitals. How do we go about accreditation? We have a team that comprises of the main leader of the college, the council member, most likely, the specialist of that area that we need to accredit the hospital for, the medical council team, the hospital leadership in assessing and verifying that the hospital is eligible to train that specific specialty. And in terms of training, we develop a cohort or a faculty of trainers, and these are program directors that are based in country, but within the hospitals. And out of those trainers, we also train them to become master trainers to be able to deliver. In most cases, we do not concentrate on the standard training program, but we also train them in terms of the critical non-clinical areas like leadership, teamwork, communication, and quality care. Our approach in terms of this is harmonizing the standards within the region, harmonizing the curriculum, and coordination of various institutions, including governments and other colleges among ourselves to be able to deliver as one voice. That's a picture of a slide that shows accreditation visits in some of the hospitals, Moi Teaching Hospital, Coast General Teaching Hospital, and Bugando in Kenya and Tanzania. So those are the teams that we incorporate for them to be able to assess a training site eligible for training. We have so many hospitals. In total, there are about 149 spread across the ECSA region. Can you take me to the next slide, please? Okay, so having had the accredited training sites, what is our coverage as colleges? We occupy 26 in terms of operations. The DG already mentioned, ECSA has 9 countries, but it's delivering beyond the 9 countries through different programs, projects, and colleges. The colleges operate in 21 countries and beyond. And colleges serve a population of about 500 million of all the combined countries. The map we have, the first one is ECSA. The big one takes all the colleges. The other one, second one is COSEXA, CANEXA, EXACON, and EXACOG. The areas highlighted are the areas where we are present in terms of training. In addition to on-the-job training or hospital training, we also take our trainees through e-learning. We have the management systems, the online management systems that have the resources of training. And as a college, COSEXA, CANEXA, we have School for Surgeons, where all the resource materials from different institutions, those developed by our experts, our surgeons, anesthesiologists, and several others, are uploaded onto the system, accessed by all our trainees, our trainers, and our fellows. During the training in the countries and in hospitals, our trainees are expected and must register or record the operations they undertake in the electronic logbook. And this is one of the mandatory requirements for them to be eligible to sit their examinations at the end of the training. I want to report today that the surgeons have so far recorded 550 operations in the e-logbook with different cases: pediatric surgery, plastic surgery, cardiothoracic surgery, urology, and so on. EXACOG still also has an e-logbook, CANEXA has an e-logbook. So we can use the e-logbooks, one, in enhancing the health systems because we have the data, registering the cases, the modality of the cases, the complications, the post-operative and perioperative. In that, we can do evaluations assessed by doing surgical audits in order to inform data and policy making. I'd already mentioned about the training and the trainings. We do clinical on-the-job training, case studies, mandatory courses, strict logbook review, and assessment of our trainees. And at the end of the day, our training culminates into a standard examination for all trainees. Part 1 is paper-based, which is multiple choice questions, and objective structured clinical examination at MCS level, and short and viva at Fellowship College of Surgeons or College of Anesthesiologists. These are the two structured examinations that our trainees undertake to be eligible to operate or work on patients out there after their examinations or graduation. IT. So ultimately, what are we talking about? I'm going to explain this slide in line with the idea of establishing colleges. The main objective of establishing colleges: one, to bridge the gap between the patient and that specialist, to increase the number of health workers in the region, two, advance retention of medical specialists in the region. And what are we saying here? To date, we have a total of 1,460 trainees undertaking training in various colleges. We do have a number of 1,011 trainers in the colleges. We have 216 training sites where our trainers undertake their programs. We have already graduated 942 in total. We did a survey in 2020. It indicated there was 88.8% retention rate or retention level. We recently did another survey. Still, we are standing at 88. And the retention in the region is at 93. The 88 is in country, 93 is at a regional level. The chair is clapping for me. I think the rest can clap. Thank you. 64% of the training sites are not in cities. They're outside the cities. And if we look at universal health coverage, or SDG 3, good health, well-being, accessibility, affordability, and bringing the services to the needy, we are outside in the rural areas, and that's where we are undertaking our training. So we've answered the call of the health ministers by their resolutions, and we are still committed to delivering as mandated. The trends there show the enrollment of trainees onto the training program in the colleges. And the reason we are showing that graph is to show how we started with small numbers, but today the numbers double. The exponential increase in numbers of trainers is so high. Same applies to ECSA-CON and ECSA-COG. ECSA-CON recently introduced its new programs, and they've started on a good note with very many trainees. The graduates, as you can see, I always want to put that by country so that we all know where we are lying. As we speak, Kenya is very high, and I want to appreciate the chair, DJCC, because Kenya is running so fast in terms of training the health workforce, followed by Ethiopia, Zambia, Uganda, Rwanda, and Tanzania. So I want to urge all of us to support our trainees out there in different capacities to increase the health workforce in the region. Improving skills and quality of the health workforce. We all know that it's not about training and having trainees on ground, but what else do you do in terms to continue enhancing their skills? So the colleges also undertake different other trainings in terms of enhancing the skills and developing their capacity. So far as colleges, we've trained 234 rural health providers. We've had CPD programs and trained 240. We also support our program directors who are faculty members. They are not paid, but we always find opportunities for them to enhance their skills. And they right now undertake postgraduate clinical leadership course at the Royal College of Surgeons, Ireland. We also offer research grants to our trainees. We offer scholarships, and as of today, we've given out like 500 scholarships for training. We always want to exchange our trainees between different countries so that they learn from the best or from the other centers of excellence. And currently, we've exchanged 39 trainees. We do have workshops in perioperative nurses. We also offer scholarships to program directors and post-fellowship fellows. And these are fellows who have completed at our colleges, but we still want to follow them up and support them, not to pass them and drop them. We also have courses in helping babies breathe. We've trained 125. We also have a platform for disseminating research. The College of Surgeons has a journal, and I want to urge you to disseminate your information through our college. It's on the website, very accessible and effective. In addition to formal trainings, colleges have continued to offer scholarships specifically for women. The question from, I think, Kenya, Kemri, to the DG, how ECSA is mainstreaming gender. In addition to what the DG mentioned, mainstreaming gender across other activities of ECSA, the colleges also resource mobilize for scholarships earmarked for women, and we are supported by the American College of Surgeons and AO Alliance to offer scholarships just for women specialists. These are our partners. It's a mouthful because we are many. It speaks to all colleges, but I want to, don't see the partners and think we are okay in terms of funding. Some of the partners that provide support to colleges come to develop resources for training, examination, volunteering, and a few provide funding. So the partners in the room, the colleges still need funding. These achievements, I've already talked about them. They speak to the mandate. I'll skip. Challenges. The retention is high, but the population is increasing. The survey we did last year indicates that much as the rate of the trainees or the specialists is increasing, also the population is increasing by double. So we have a huge task at hand to increase the efforts to be able to cut down the gap. Access to health care is still low, much as we have our training in rural areas, but after training, our specialists tend to leave the villages or rural areas to urban areas for employment. And you find them stuck in the cities, unemployed due to poor infrastructure, the mix in their rural areas. So there's low employment absorption of specialists, and we urge countries to help us and take on board our human resource specialists. The lady from Zimbabwe mentioned they have vacancies of 5,000, and I believe those will be filled by specialists from colleges. The funding gap, this one speaks to trainees' need to train, but not able to meet the cost, and the women enrollment, which is still low. An example is of COSEXA enrollment. We received 468 applications, but are only able to onboard 288. And when we inquire from the trainees that dropped off, all they say they could not afford. In 2021, applications were 598. Half of those were taken on board. In 2022, applications were 610. Close to half of those were dropped. 2023, the same thing. Female enrollment is still low. May we please try to embrace gender equity, gender balance, and gender mainstreaming to increase the number of women on our programs. I'll give a few recommendations in line with the challenges. One, as colleges, much as we are in 21 countries, we are still facing challenges of recognition. Yes, we're established by ministries of health, and we are approved by the medical councils, but we are not yet accepted in some of the countries. They approve you, they give you the certificate. When the trainees finish, they tell you we do not recognize that training. Those are few countries, not all, but we want to request countries, please. These are colleges that were established by yourselves. Help us to recognize the specialists because we need them to close the gap. Funding support, we may not need funding to colleges directly because we know funding is a problem. However, we can do tripartite agreements or bilateral agreements. I'll give an example in the next slide. We also request the establishment of skill centers in different hospitals to support the training that we are undertaking, the scholarship support to trainees, at least within your countries, and then absorption of these specialists at the end of their training. An example of a tripartite or bilateral, in 2022, Uganda was able to negotiate a grant with the Duke University specifically for surgeons undertaking neurosurgery at COSEXA. So you may not give us funding directly, but if you have grants that you're negotiating, you can negotiate capacity building of human resources for health, specifically targeting the colleges at ECSA Health Community. At the end of the day after training, we would want to have such big numbers at our graduation ceremonies. I always end my presentation with this. One, for us to have an efficient education system, training system of specialists, there are 4 cornerstones, and would want to know the missing link. If the health ministers established the colleges, that is government intervention. We have the colleges in place, we have dedicated personnel, the leadership is also dedicated. We have trainees that are willing to undertake training. You've seen how we've been dropping them, but we do miss the required resources, and that is funding and several other support to health workforce development. The curriculum is based on international practices, so the missing link, I think we can all tell what is missing in our efforts to deliver. Thank you.
Thank you, Mayor Itungu. We've been chided for time. We are a little bit behind colleagues. So at this point, I will kindly ask that our roundtable discussion please be summarized. Maybe we'll probably have the time that they were given. So we would like to welcome at this point, Professor Bekele, the Secretary General of ECSA. This is the College of Surgeons of East, Central, and Southern Africa, to please come and lead this discussion. Professor Bekele, oh, there he is, thank you.
Good morning, everyone. I guess it's a good afternoon now. My name is Abebe. I'm a surgeon. I serve as SG of COSEXA at the moment, but my paying job is I'm the Dean of the School of Medicine at the University of Global Health Equity in Rwanda. I live in Rwanda at the moment. It's an honor to welcome you all to this important panel discussion on health workforce development, particularly focusing on the surgical workforce in Africa. Hopefully our gathering today is more than a dialogue. It's a call to action to address one of the most pressing health challenges of our times. The WHO estimates that to achieve universal health coverage by 2030, the world needs an additional 18 million health workers. In Africa alone, the deficit is very staggering. We need about 4.2 million more health workers, including surgeons, anesthetists, and obstetricians. This shortfall critically hampers our ability to deliver essential surgical care. Studies show that up to 93% of the population in sub-Saharan Africa lacks access to safe and timely surgical care, which is an unacceptable disparity. To bridge the gap, we must invest in robust health systems that prioritize training, retention, and equitable distribution of the surgical workforce. Evidence suggests that countries with well-structured health workforce retention policies see substantial improvements in the distribution of health professionals to underserved areas. We probably should embrace task shifting as we move forward, where appropriate, empowering non-specialist clinicians to perform surgical certain tasks. Today, our discussion will delve into these and other solutions, drawing on the collective wisdom of our distinguished panelists. Let's approach this dialogue with a shared commitment to partnerships and innovations, recognizing that the health of our communities depend on the strength and capacity of our health workforce. Thank you, and I look forward to a fruitful and engaging discussion. At this juncture, I would like to call the following four panelists. They probably do not need any introduction, but to fulfill the formalities, please allow me to welcome Professor Dambisa, Dr. Diamani, Professor Kimuli, and Professor Mpoki to the podium to join me in the panel discussion. The format of the conversation would be, I will throw one round of questions to all. I will then open it up to the meeting here, in case there are questions that you would like to pose to them. If time allows, I will throw another round of questions to all of them. Thank you very much, everyone. I will start with Professor Dambisa. We always talk about shortages of the surgical workforce, the shortage of the workforce in healthcare. But do we, as individual countries, or as a region, or as a continent in a broader sense, know our exact health workforce deficit or the need? We always quote WHO figures for 4 healthcare providers per 1,000, or the surgeon to patient density, 20 per 100,000, but that represent us. Do we have our own numbers?
Thank you very much. I thought I shouldn't speak anymore because It's becoming too much for the audience. I'm aware that there have been undertaken steps to develop national surgical and anesthesia plans, which suggests to me that as part of that process, there should be a situation analysis that should identify the capacity gaps. But I'm not aware to what extent that has been. Fortunately, we have the countries here. But having said that, I'm also aware that even the WHO figures and projections ultimately are contributed to by what we submit to WHO. So we should intuitively, if not empirically, we should intuitively have an idea about what our gaps are. I also know that sometimes the gaps are driven by the kind of capacities we have within the public sector. If I have 6 hospitals, each needing 2 surgeons, it's easy for me, wherever I'm sitting, to say I have a shortage of 12 surgeons. Now, that might not translate into the ideal, but for purposes of delivering on the health service, that would be a starting point. So I'll flip the question back to you, maybe to put to the rest of the House, to tell us the extent to which those figures are available in the various countries. Thanks.
Thank you, DG. I'm going to now ask the presidents of the 3 colleges in front of you a similar question, but tagged into the question I asked to the DG. How does your current training program in your respective colleges address the needs of the shortages of the workforce in the region? If you could first start with the perceived deficiency in the region, if you actually have the data in the region, and then what you are trying to do to address the problem.
Thank you very much, Program Director. I would like to write upon the protocol that has been observed by the rest of our colleagues here. My name is Dr. Glory Msibi. I am the president of ECSA-HC, which represents nurses and midwives in the region. We have a footprint in 17 countries. And probably as an acknowledgement, I would like to acknowledge the minister's foresight when they started these colleges, because by then, from the DG's presentation, I saw a picture of 1976 that comprised of the health ministers that acknowledged the importance of having a workforce in our various countries. And to my surprise, maybe this would come as a little bit of a surprise to many, the minister then of the Kingdom of Eswatini was my brother-in-law, who was the Minister of Education and Health. So I was very much thrilled. Coming back to your question, say, how do we then do or conduct our trainings as a college? I think the message from the ministries from the onset was very clear, that there is shortage of workforce in the region, and we needed to respond to that. But like many speakers have alluded to, that resources were not permitting at that time. But our pioneers who came before us, they worked very hard, because there are some documents that they produced which talk to the training of workforce. From the nursing part, I remember there was a regulatory framework which countries used to improve regulation of the nurses and midwives in their countries. So coming back to where we are now, yes, we are 34 years. We are the oldest college in the region. we've not been training, and COSEXA came late, 9 years later than us. Then they ran with the training of our workforce as countries. So for us as nurses, we are now on board in the training of nurses. I think Stella has made my presentation very easy because she has mentioned the programs that we are offering as ECSA-HC, and that came from the report, the ECSA report on nursing education and the labor markets. So we are responding to that. We saw that during the COVID time, we were unable to meet the quality that was so required by our consumers of our services in terms of critical care. That is why we are having critical care as a program. And we also saw that we have an increase in non-communicable diseases that is surging in all our countries here. So from my country where I'm coming from, what I like the most is that we have distributed the management of NCDs in the primary level. That is done by nurses. So in that way, I think as a college, we are responding to the needs of our communities. And again, we have the other program, which is the neonatal nursing care. When you look at the statistics that we have in terms of mortality and morbidity of neonates, yeah, it's very much alarming. And the disease burden in our continent is very much alarming. And yet the workforce is not matching what we are experiencing as a region. And we also have midwifery. Midwifery, why midwifery? Midwifery because we also looked into our maternal mortality rates that we have as countries in the ECSA region. And for purposes of maybe saying we are not training the basic degree. Our focus is on postgraduate programs because we want these nurses to do more than what the present nurses are doing now. So that when they go out there, they add value to the communities. We produce nurses that are fit for purpose. We produce nurses that are competent enough to provide that quality health service to our communities. Probably may I just stop there. There's a lot that I can talk about concerning the college. We are very much passionate as presidents of the colleges. Like, we are not paid, but we are doing this voluntarily. And we also want to congratulate the countries that have approved our programs so that when our graduates graduate, we know very well that these graduates will be recognized in their countries. And we implore those countries which have not yet approved the programs to do so. Thank you very much.
Thank you. Professor Nakimuli, President ECSA-HC.
Yeah, thank you, Chair. And in the interest of time, allow me to ride on the existing protocol. As I've been introduced, I'm the president of the ECSA College of Obs and Gyn, but also my day job is Dean School of Medicine at Makerere University in Uganda. So I think can use those two portfolios to answer this question ably. I would like to start by reminding us of the context of Sub-Saharan Africa as far as maternal and newborn health is concerned, whereby we know that over 60% of the maternal deaths in the world are happening in Sub-Saharan Africa, and actually also majority of the newborn death.
And we also know that most of these deaths are happening within our hands. And that is mainly efforts to push mothers into the formal healthcare system working, but then the quality of care letting them down. They don't get as enough in terms of comprehensive obstetric care. Many mothers who would need a cesarean section don't get it. Actually, we know that we are very much generally below 4% as a region in terms of cesarean section rates. But again, related to quality of care issues is that many mothers also end up with complications from the cesarean sections done or from not doing them in time, such as obstetric fistula, which means that, again, we are having a lot of issues with quality of surgical capacity, and which is very disappointing. Of course, I know that maternal newborn health is largely multidisciplinary, requiring a lot of colleagues around the room, anesthesia, nursing care, in addition to obstetricians. So I will just try to say we know that sometimes what is letting down is the incomplete teams, and again, trying to show the context in Africa. But even where teams are complete, I would like to point out that sometimes even the obstetricians are too few. We all agree that we don't have enough data in terms of the health workforce required, but sometimes it is strange. We've had countries in our region, in our college, where you can count the number of specialists, obstetricians, and gynecologists on one hand. And that has actually made things very difficult in that country. Just wanted to say that context, but move quickly to saying how is our collegiate training trying to address these issues, the quality issues, the issues of mothers being in the rural areas and not having access to the healthcare providers that would help them survive these complications. So our training, first of all, like most of the ECSA colleges, has focused a lot on training people where they work, which we hope will help with retention, and is already showing so, especially with the colleges which went before us, like COSEXA. So we've focused a lot on that, but also we are trying to make it a very clearly and heavily competence-based curriculum where we are focusing a lot on skills and, of course, the knowledge we know about the region to try and address the training such that our trainees at the end of the day are very competent to offer safe surgery and quality care for our moms and newborns. The other one is to try and make sure that we really work with all the teams that are important in the care for moms and babies, the anesthesia, the nursing care, and others. And this has meant that wherever we develop our training program, we try to make sure whatever we plan, we are very much working in hand with these cadres, but also where opportunities allow, we also offer them the training to build their capacity so that we are able, at the end of the day, to provide the moms with the quality care surgical care that they need. So briefly, that is what is happening in the college, and I will allow my colleagues to say more. Thank you.
Thank you. President Poki, President ECSA.
Thank you so much, Professor Bebe. I want to thank our sister Stella for the presentation that she made, but I would like to submit a little correction that the College of Anesthesiologists is offering a 5-stream training. We offer anesthesia, we offer critical care, we offer obstetric, pediatric, pain, and critical care. I'm stressing on critical care because we've not invested so much in that particular area in offering the training, because in the past, that's traditionally it was anesthesia and critical care. But now we've realized it's a line that requires an appropriate investment. Answering the question that was posed on how did we determine on the magnitude of the gap, the college embarked into studying the situation on the ground in the region. So between May and September, the year 2020, we conducted a survey of the anesthesiologist workforce in East, Central, and Southern African region. And our findings were published in Anesthesia and Analgesia 2021. I would like to summarize the findings, Mr. Chair. Only 411 anesthesiologists were found in all the countries that were surveyed. This formed 0.19 per 100,000 population, the anesthesiologist. So the gap was 5% of the internationally recognized numbers that were required. So that is globally. But specifically, each country, those that have conducted the National Surgical Obstetric and Anesthesia plans, they have addressed the need specific to the requirement in their countries. Tanzania has done it, Zambia has done it. Tanzania was the first in the world to even cost, and that is what has been guiding us. But generally speaking, with the understanding that the gap was so huge, strategies were employed, and these were guided by the College of Health Sciences Senate that has made sure that we have a benchmark for training in other colleges, making sure that our curricula is approved by the relevant bodies that oversee our medical professions in our countries. So what Professor Nachimuli was saying is exactly what other colleagues will be saying concerning training. Recruitment, again, is based on institutions where we have people that can offer training. These will be fellows, either foundational or those that have done exams and have qualified, and this will offer in areas that will make these people competent, comparable to individuals that are doing MED. And because our programs are internationally benchmarked, we expect the quality to match any from any other place around the world. Our examinations are conducted so rigidly that when we say you've passed in our college, for instance, we know you can pass any other examination that is offered in the world. Wherever you have a surgeon, you need an anesthesiologist. The College of Surgeons for East, Central, and Southern Africa has led the way, but also we want to acknowledge the role that they played in trying to pull the rest of us to work with them, because quality of surgical outcome cannot be guaranteed in the absence of adequately trained anesthesiologists and those that will care for those patients after surgeries have been carried out. And so, in short, that is what is happening on the ground. We are not where the surgeons are, but we are not where we were when we started. Yeah, our college, for instance, has already made an output of 128 anesthesiologists, and we are the underserved because of the interest that people have in studying that the profession. But since our services are required by orthopedics, obstetricians, gynecologists, you talk of general surgeons, neurosurgeons, and everything, so the encouragement is even greater. The critical care caters not only for the doctors, but also for the nurses. And so we come to a place where we use our resources in a way that we can complement, but also reduce the cost in employing what is existing in training, irrespective of the various curricula that each profession has on the table.
Thank you, Professor Mpoki. If we, as a region or as a continent, embrace the Lancet Commission recommendation or the WHO recommendation for that matter of 20 practitioners per 100,000 population, anesthesia is about 0.2 per 100,000, and surgery was 0.53 7 years ago. We're now at 1.1. You can see there's a very huge gap, a disparity. Again, what I mentioned earlier, is the Lancet Commission recommendation applicable in Africa? Does the mathematical modeling hold true 10 years since it was formulated? If that holds true,
we are in a real serious challenge. Maybe it's now time for the College of Health Sciences to think about another survey to understand where we are in terms of the 8 professions: surgery, anesthesia, ophthalmology, pathology. Maybe something to think about, DG, as we move forward. Before I invite the audience to ask one round of questions, brief question to the presidents of ECSA, COG, and CANEXA. What is your college's stand in regards to task shifting and task sharing? Very brief response.
Yeah, thank you, Chair, the session. Well, task shifting, again, is one thing which we need to appreciate that works when the context is got well. It's not a one size fits all. And we know, for example, actually probably a good question coming to me as an obstetrician is that to us, it's very natural to task shift or share with midwives, a lot of our roles. But what we know also that in some settings, they really do not have the healthcare workers to provide that care, and that would be the alternative. For example, where people have tried to innovate around surgical technicians, where there are no doctors to do cesarean sections. But we also know that in some of the places, the issue is that these people, the cadre exists, but they are just not being employed. So then it becomes a problem. Whatever the case, task shifting requires adequate training and supervision. And without those 2 critical elements, then it runs the risk of being a danger to the population that it is meant to serve. So allow me to leave it at that, but I know that is an issue that is thorny in some circles. Thank you.
Oh, thank you very much, Mr. Chair. In the field of anesthesiology, mostly we do task sharing. Task shifting, we haven't had the capacity to effect that across the board. And the reason for that is because we've had surgeries being carried out in our region even before anesthesiologists were trained. So non-physician anesthesiologists have been providing the services, and they still provide the services. In the region at the moment, we have about, let's say about 1,000 anesthesiologists, but that is less than 5%. The problem is with the burgeoning population when people get born and the numbers get big. So the numbers keep getting smaller unless my colleague here limits the process. That's a serious one. So task shifting really cannot be an item that we can address with the confidence. But sharing, we work with nurses and clinic officers in places where we cannot provide sufficient numbers of anesthesiologists, and they've been doing a wonderful job. And the beauty about it is that that's not just for the region; it's around the world. Wherever we have shortages of anesthesiologists, and those people that are trained to serve up to a certain level and tell when they cannot meet the requirement in a patient and transfer or refer, they've been doing a very good job. Task shifting, I want to stress, we've not come to that level yet.
Brilliant. Thank you both. Let me now invite 1 or 2 questions from the audience, if there are any. Yes, 1 and 2. If we could start from the gentleman in the middle.
Thank you very much. My name is Professor Moyo from the National Institute of Science and Technology in Zimbabwe and from Baines Occupational Health Services. I think my comment is, I think the college has done exceptionally well in terms of training. This is just more of a suggestion, or maybe I could be behind. I think one of the major issues within our context and region mainly pertains to research. across all disciplines, from the surgeons, from the anesthetists, across. I think that's one area of focus which maybe the college should extensively look into, so that we generate the evidence that drives practice within the African context. I think research has been a major area of deficit to date. So it will also be good to hear from the colleges how they've done it. But from my experience, I think we still need a lot to be done. Secondly, more of a suggestion really, or recommendation, is that if the colleges can also consider issues of critical skills training on a short-term basis. It takes at least 4 or 5 years for specialists to go through the various fellowship programs. But in terms of our African setting, there could be medical issues that require critical skills within a short space of time, so that if the college could maybe also consider offering, these could be cross-cutting critical knowledge areas or short courses, so to speak, in the different disciplines. Thank you.
Thank you very much. Both very good comments. I don't think they need any response from the audience, but very good comments.
Yes, thank you for this discussion. A good progress in the efforts in training. But I think the key bottleneck is issues of absorption. Because I think if those who are currently trained are absorbed, then the numbers which we have could probably even be double. So I think we need to increase the issues of advocacy. Yes, we'll have the ministers of health, but I think the ones whom we need to target the minister of finance. Because if we have these discussions ourselves alone here, then we'll not take it far. So I think we also need to, yes, get money for more training, but also get money for recruitment.
Thank you. Another fantastic comment. To conclude the session in the interest of time, I want to throw one last question to the DG. Do you think the region can achieve its workforce goal in the near future? And if yes, what do you want us, the colleges, to support you in, to help you in?
Thank you. I was waiting for you to say if no, then don't say anything. But then you rigged the question and forced me to go for the yes way. No, we have the capacity to meet the shortfall, and we have the young population that is waiting to join the labor markets. And the little I know is that healthcare is still very attractive to the young people. So what we need is to keep them interested in the health sector. They will apply to come to the professions. But then we need to make sure that what the director from Uganda has just said is taken care of, so that they don't face, they don't look at possibly being frustrated after they complete, because that's a disincentive. But if they know that upon completion, they will be absorbed and they serve, then that's fine. Of course, beyond the talking to finance to allow us expand the numbers, we also need to broaden that discussion to include improvement in the general conditions to make it more attractive. But on the basis of the kind of reports we get on the growth of our GDPs and so on, I'm sure if we deliberately push the agenda and have our governments committing commensurate increments of resources to training, that will be achieved. But secondly, all our countries are registering improvements in private sector expansion. And I am aware that most of our countries have liberalized the training of health professionals. So if we make it worth the while for the private sector to invest in training more health professionals, plus the initiatives from the public sector side, we shall get there. Whether we will be able to retain all those we train, I think is a question for another time. Thank you very much.
Thank you, DG. Well, it's not usual to have 3 presidents and the DG in one forum. It's not it's very unusual, but in the interest of time, I think we have to stop here. Please join me in thanking all of them with one round of applause. And let's close this session now. Thank you very much.
Thank you very much, Professor Pekele, and thank you to our panelists for a vibrant discussion. This concludes the session, ladies and gentlemen, and I think we've really covered or discussed to some depth the issues of training with a big question mark on retention. Maybe just to say, and for another discussion, that as the DG was saying, there are other issues. HRH is a little bit complex. We do have to think about motivation. We do need to think about incentivizing people to stay and keeping their focus after training them so much. And then how do we, and think about the conditions of service and living conditions. People are happy to stay somewhere remote provided there are basic services. So I think we do need to meaningfully engage our ministers of health around these areas. If you're going to post a doctor 500 or 300 kilometers away, they must have somewhere to take their children to school. Without that, they will end up migrating somewhere else. So with those words, thank you very much for being attentive in this session and for being engaging. I thank you.
That was amazing. Another round of applause for everyone who participated. A few announcements before we go ahead. Basically, we'll go for lunch, and the next session will come after lunch because of time. I hope next time we'll be a bit faster, and we'll work more with the time that we have in hand. And I'll be back here at 2:45. But a few delegates sponsored by ECSA-HC should see the secretariat at the registration desk. That is announcement number 1. And second, lunch is served at Sabasaba restaurant. Participants should collect meal coupons at the exit from the ushers. So as you go out, then you'll be collecting the coupons, and we advance to Sabasaba restaurant. And again, I'm told that there is a first aid room just near the washrooms. Otherwise, I wish you the best and enjoy your lunch. 2:45 will be in here.